The goal of Screencast 2 will be to apply knowledge to the assessment of each of the 3 groups of chronic diarrhea so that we can rationalize the workup in each case. We also aim to fill in the algorithm that I had started earlier while emphasizing 5 pediatric conditions of importance in the workup of chronic diarrhea that you may not have seen in adult care. As I had mentioned, you can consider some investigations after your history and physical. However, without a clear diagnosis, I'd suggested classifying the patient's diarrhea as either inflammatory, fatty, or watery. We'll start with chronic inflammatory diarrhea because its differential diagnosis is quite brief. The 3 conditions I've listed here account for the vast majority of all cases. In all of these cases, the distinct clinical features are blood and mucus in the stool, which indicate chronic mucosal inflammation and disruption. Other supportive features would include tenesmus, frequency and urgency, which would suggest proctitis, unexplained fevers or impairments in growth or puberty, or some of the extraintestinal symptoms related to the inflammatory process. Last, there are some supportive tests, including increased inflammatory markers on blood work, stool being positive for white blood cells or occult blood, or signs of inflammation of the bowel on imaging. Despite a commonly held view, chronic infectious gastroenteritis is rare in the developed world amongst immune-competent children. Viral infections, in particular, rarely persist beyond a week and do not cause bloody diarrhea in this group. Rather, with bloody diarrhea, I would consider the invasive infections, which include bacterial infections most commonly, and I've listed a few examples of these here. Please note C. difficile should only be tested in the right circumstances in patients older than 2 who actually have the receptors for the toxin and are thus more likely to be infected rather than a chronic carrier. And last, parasitic, including Entamoeba histolytica, which is an invasive parasite that is actually endemic worldwide. So the infectious workup thus follows from the knowledge of what the most likely pathogens are in this situation. I do want to point out, however, that we now have a PCR-based test with greater than 95% sensitivity for the 4 protozoa that cause the vast majority of infections in immunocompetent patients among parasites. This is now the preferred test in immune-competent patients in the developed world. Moving on, allergic colitis is a condition almost exclusive to pediatrics. Cow's milk protein allergy, sensitivity, and intolerance are often used interchangeably to refer to the condition, but the preferred term is now dietary protein proctocolitis, even though it's a mouthful. There is certainly some evidence suggesting to the possibility of an allergy, most notably the eosinophilia seen commonly in colonic biopsies, peripheral blood, or the stool in these patients. While many consider it to be a non-IgE mediated allergy, this is not completely proven, and that's what the term acknowledges. On the other hand, however, intolerance and sensitivity seem to be 2 nondescript terms. And while cow's milk protein is the most commonly protein implicated, the term dietary protein is preferred initially because 50 to 60% of patients are exclusively breastfed and may be reacting to one or more of the many proteins in mom's diet that are transferred through breast milk. Even in formula-fed infants that only receive cow's milk protein, about 25 to 50% of them will be cross-reactive to soy protein. Patients classically present within 2 months of life, but as late as 6 to 12 months, with progressively increased blood and mucus in the stools. Interestingly, diarrhea may not be seen, but many do have more loose and frequent stools. Also importantly, the infant should be otherwise well and thriving, and only 10% of these patients have a family history of the condition in a first-degree relative. This is considered a clinical diagnosis, and biopsy would only support it, while blood work is usually nonspecific. Removing the suspected offending proteins is considered to be both a diagnostic and a therapeutic challenge. For exclusively breastfed, you can support breastfeeding as the mom excludes cow's milk protein from her diet. Some would suggest that soy be removed as well because of the high cross-reactivity, whereas others will do a stepwise exclusion. If moms prefer, or if the infant is formula-fed, we recommend a hypoallergenic formula where the proteins have been broken down into amino acids and short peptides. It can take weeks for symptom resolution, but the trend should always be for improvement, and only more complicated cases need to be referred to GI. Last, in this scenario, parents should be reassured that bleeding rarely causes anemia, and if the issue is cow's milk or soy protein related, nearly all infants will tolerate reintroduction of the foods by about a year of age, when most will suggest reintroducing. To close the chronic inflammatory group, remember that if an infectious or dietary-related cause has been excluded, then the patient requires an urgent referral to a pediatric gastroenterologist because of the high likelihood of inflammatory bowel disease. Additional blood work and clinical status will be important here in determining how urgent this will have to be. Fatty diarrhea is the next category. Clinically, stools are often bulky, foul, oily, or greasy and may float in the toilet, which indicate high fat excretion. Just be aware, however, that stools may actually be watery in some cases because of malabsorbed fatty or bile acids, which stimulate chloride and fluid secretion. Because fat is calorie dense, another big take-home point is that the vast majority of patients in this category will also have signs of malnutrition. First, a quick reminder that what we often term fat absorption actually involves many steps. Digestion depends on the action of the enzyme pancreatic lipase, while bile acids facilitate the process by emulsifying fat and solubilizing the free fatty acids. The other key step is fatty acid absorption across the small intestine. Fat malabsorption is thus either due to one of these three problems usually. Fat malabsorption can be difficult. Microscopy for fat globules is often quite subjective and depends on recent fat intake. And finally, will not pick up fatty acids routinely in the scenario when absorption is the problem across the small bowel, but the digestion is fine. The gold standard requires collecting stools for 72 hours, measuring the total fecal fat in grams, and then determining the excretion as a percentage of the documented 72-hour fat intake. Normal values are age dependent and are based on the fact that fat absorption is actually less efficient when you are younger. Last, the presence of one or more fat-soluble vitamin deficiencies will also support the clinical picture and are important consequences of fat malabsorption that you should be looking out for. In pediatrics, fatty diarrhea is usually related to small bowel disease, which is either an immune-mediated process or related to an infection. This is why whenever fat malabsorption is suspected, you should screen for markers of inflammation or for deficiencies of other nutrients whose absorption would be affected across a diseased small bowel, or lost as protein in the case of an enteropathy. Within this group is an important condition called post-infectious enteropathy, or goes by another couple names there. As all of them imply, the patients present with persistent diarrhea after an apparent acute gastroenteritis. However, such patients often have fatty diarrhea or watery diarrhea with weight loss. The evidence suggests that these patients have a delayed recovery after an infectious injury, with immature, underdeveloped, or atrophic villi in the interim. The biggest risk factor for this condition is pre-existing malnutrition, and in industrialized countries it mainly affects infants because they are more susceptible to malnourishment during acute illness. Thus, both treatment and prevention are based on avoiding suboptimal nutrition, and primary care providers have a crucial role here. Main points in dietary advice around acute gastroenteritis are as follows. Infants who are tolerating breastfeeding should always continue to do so. And early feeding after a short period of rehydration is recommended whenever possible because this can stimulate mucosal recovery, shorten duration of illness, and improve nutritional outcomes. Last, it should be emphasized that restricted diets are often unnecessary because they provide suboptimal protein and fat, which are important in the recovery process, and or they often can be high in simple sugars that actually may increase stool outputs. In pediatric patients with chronic fatty diarrhea, you must consider pancreatic exocrine insufficiency, which is nearly always due to cystic fibrosis. A very good non-invasive screen for pancreatic insufficiency is by measuring the proteolytic enzyme elastase in the stool. Because levels reflect enzyme secretion, low levels are thus abnormal. Last, a sweat chloride should always be ordered in these cases. Finally, bile acid deficiency related to chronic cholestasis most often can clinically present with jaundice and acholic or non-pigmented stools, associated with elevated conjugated bilirubin, GGT, cholesterol, among others. It also results from decreased bile acid reabsorption across a diseased or resected terminal ileum. In sum, if a child has chronic fatty diarrhea or watery diarrhea with failure to thrive, assess for fat-soluble vitamin deficiency and initiate tests to help narrow the differential to one of the three main categories. GI referral is likely warranted and often expedited to prevent further malnutrition. The last phenotype is watery diarrhea, which has a wide differential diagnosis. But in pediatrics, it's more likely to be benign, and a few steps can often yield a diagnosis. So to start, consider red flags: nocturnal stools, profuse diarrhea, or failure to thrive. Then you should review history for sources of osmotic diarrhea, especially lactose, fructose, sorbitol, or osmotic laxatives. Next, consider functional disorders, particularly if the age of onset is less than 3. Toddler's diarrhea is a very common clinical diagnosis with the official Rome 3 criteria listed, the first two of which really just describe a chronic diarrhea of greater than 4 weeks. Onset must be in infancy or preschool, during the age where this is actually the most common cause of chronic diarrhea. The absence of nocturnal stools is an important criterion. Classically, these kids have large formed or semi-formed stools after waking, then smaller and more watery stools as the day progresses, and classically undigested food is reported in the stools. Last, these children must be thriving. And like any functional disorder, there should be no suspicion of an organic pathology. While this is technically not a diagnosis of exclusion, there is still some debate as to whether or not screening for celiac disease or chronic infection is required. Pathophysiology is unclear and likely varies from person to person, but most theories involve osmotic effects of simple carbohydrates or rapid transit, especially postprandial. Management is centered around reassurance. If fructose, sorbitol, or sucrose are high in the diet, then they could be limited, but you should avoid other dietary restrictions that may limit caloric intake. Its resolution is expected by the age of 5. If functional disorders are excluded or secretory diarrhea is suspected, there are some other considerations. First, infections need to be assessed if not already done, particularly Giardia lamblia and other parasitic infections. Giardia is the most common pathogenic intestinal parasite in North America, and it is mostly sporadic. Fecal oral transmission of Giardia cysts can occur, making children attending childcare centers or in areas with crowding and poor hygiene as high-risk groups. However, waterborne transmission is the most common. Cysts are fairly resistant to chlorination, so outbreaks in communal swimming areas are not uncommon. Also, boiling inactivates cysts, but swimming in untreated stream and river water is a risk during camping. Giardiasis was specifically not mentioned in the inflammatory group because it does not present with blood, mucus, or white blood cells in the stools. Inflammation and injury can occur, but it is usually in the proximal small bowel. Diarrhea is most often watery, but can be fatty. Weight loss, crampy abdominal pain, and flatulence are also very common. Diagnosis, as mentioned, is by PCR testing, and the first-line treatment in Canada available is 5 to 7 days of Flagyl. In the rare event that you have reached the end of the secretory mixed differential from the watery diarrhea and you haven't found anything, it is probably appropriate to consider these things as well as some causes of fatty and inflammatory diarrhea, and then GI consult would be very appropriate. Thank you for listening, and if you have any other questions, please feel free to email me or look at the references provided in the objectives. Thank you very much.